Hello, this video is for lower blepharoplasty. So we do here an infra subciliary incision just below the lower eyelid margin and extended laterally to the lateral orbital margin, and then we'll cut the muscle partially laterally and then go underneath the muscle in a plane between the muscle and the orbital septum, inferior orbital septum, and create a plane just underneath the muscle. And after creating this plane, we will just cut the muscle obliquely, as we can see, to give a rim of muscle, to keep a rim of muscle with the, just attach it to the lower eyelid margin to allow the movement of the lower eyelid. And then we'll continue cutting the muscle. We'll go in the plane and then cut obliquely, as we can see here. Through this pocket we created, we will just do some more blunt dissection in order to expose the inferior orbital septum and then see the fat herniating through it. So we have three compartments in the inferior orbital septum. We can see the middle compartment with a lot of fat herniating through this, extensive fatty herniation through the middle compartment. The middle compartment is usually connected with the medial compartment, and they are both separated by the inferior rectus muscle. We didn't expose the inferior rectus muscle here. We keep dissecting the fat from the surrounding fascia and surrounding adhesions, so that we just dissect the fat very nicely, so that when we remove the fat, we are just very happy that we are removing only fat. We are not taking any tissues with the fat, and we are just quite sure that we don't injure any structures like the muscles. So here, this is the medial compartment, you can see. So after dissecting the fat, we clipped the fat and then start dissecting using start cutting using bipolar diathermy. I prefer bipolar diathermy to monopolar. If you have radio frequency monopolar diathermy, this should be okay. I don't like to use the unipolar diathermy near the eye to prevent any heat injury to the eye and eyeball structure. We are just removing the fat here. It's coming out nicely, making sure that we have perfect hemostasis. So we're trying to dissect here the medial compartment. You can see the fat here of the medial compartment popping out. This is just a small rib into the septum, so we need to extend this a little bit and to dissect this fat. As you can see, you're just dissecting the fat from all the fascial layers around it. You can see when you dissect the adhesions and fascial layers, the fat will pop out of the compartment. As you can see, more and more fatty tissue is coming out. It is very important not to take excessive amounts of fat out. Maybe some people describe this as taking out the yellow fat and keeping the white fat, but sometimes you can't discriminate between both. Here we're taking fat out after dissecting it, so only globules of fat are taken out. Some residual fat in the medial compartment is there, so we are just tracing it and taking it out. The section around this part traced is seen. So I usually, after taking fat out, just making sure that there is nothing residual there, and as the assistant is doing, she keeps pressing on the upper eyelid in order to push the fat and it become more evident. But this is not advisable to do when you do these cases under local anesthesia. This is more medial compartment fat here, and it is aided by the pressure done by the nurse or the assistant nurse with me, as you can see here. So I'm cutting the fascial covering to get out fat globules. So when you get fat globules, start dissecting and cutting with the diathermy. Go slowly. I usually use loops, so loops makes my movement slow a little bit. Here, when I don't have much control of the fat, I get the clip, which I think is the best technique, to just hold the clip and then cut the fat with the diathermy just above the clip. So we check if there is any residual fat, and I'm checking the lateral compartment here, trying to dissect just below the orbital margin. Here the lower compartment has got very little amount of herniating fat, so I will just do some cauterization of this fat in order to reduce its volume and keep it just in place. I will not take anything out. And as I told you before, it is very important to be very cautious not to take excessive fat out, and keep good amount to prevent the hollow or cadaveric appearance of the eyelid. So you can see here some residual medial compartment fat I'm going to take out right now. As we can see, there is a significant amount of fat there. Need to take out. You can see the fat is very yellow, very clear. Everything is done under vision, under complete control. So after doing this, I usually dissect beyond the inferior orbital margin and tuck some of the fat bags, which are the malar fat bag, into the septum with some PDS sutures in order to reconstruct the tear trough, and this patient actually has got some residual area underneath, which is has some fullness in the cheek, so this would create some smallness in the cheek. Here we are closing the skin after taking a canspexy stitch, closing with 6-0 ethylene. You can see the very nice smooth appearance of the lower eyelid with no fat bags, and reconstruction of the tear trough. Thanks.